Thank you. Yeah, unfortunately, my jump drive crashed, so it's not able to download the slides either on Dell or on Mac. I luckily have a couple little notes that I can look at, but essentially, so one of the things I did want to say is I'm an ER doc. I'm the medical director at Florida Medical. Prior to that, I did have a medical practice for about 12, 13 years. And so I've seen the benefits of educating everyone in the community, not only EMS, not only obviously all the docs in the hospital, but the docs in the offices are very, very important. They need to be educated. And I would venture to say that that would be something that I would recommend to all of you, is particularly working in the hospitals, get those docs on board, because a lot of times they are probably about 6 months to a year behind. I think Nils and I have discussed this in the past occasionally. One of the things for in-house strokes, which Dr. Miskulski brought up, however, is the fact that at our hospital we call a rapid response. Where do you want? Rapid response virtually negates a little bit about all these stroke alerts. So if there's a altered mental status patient on the floor, potentially could be hypoglycemia, stroke mimic, et cetera, we call rapid response. The rapid response team, which includes critical care nurses, et cetera, go up to the patient, make the determination, is this a stroke alert or not, and then a stroke alert is called appropriate fashion. So just a comment on that. As far as our team at FMC, we do tend to practice pit crew medicine. And pit crew medicine, as everyone knows, from a cardiac standpoint and EMS standpoint, is where we're all heading and where we have been for a number of years. A gentleman by the name of Howard Mell out in Cleveland, Ohio, perfected this with cardiac arrest patients, in that his patient survival has gone from 10% up to about 30% in all cardiac arrest patients. And so essentially, just to give you a quick idea, is cardiac arrest patient, you establish unresponsiveness, they're apneic, they're pulseless. First medic that walks through the door finds their pulseless and apneic, he slaps the pads on and he starts CPR. We know that for every minute delay, we have a decrease of 50% return to spontaneous circulation, so that's number one. Number two, the next guy comes in and he gets an IV. Now, if he can't get an IV, in a lot of places they're just drilling IOs right away to decrease the time. At that point in time, he just pushes epi. The next guy comes in, he manages the airway. A lot of times we just put non-rebreather masks on because we don't have to worry too much about the airway at this point in time. We know that from cardiac arrest. We're doing cardiocerebral circulation, cardiocerebral resuscitation. And then lastly, the next person, the next medic, is talking to the family, getting some history, and obviously getting that information. So we extrapolated this, moved this into the stroke arena, and that's what we're trying to do at FMC. And what we do, excuse me, be it a walk-in or EMS arrival, obviously pre-notification by EMS is great. We get these patients that, get these families that call us right away. We get pre-notification, and the patient gets to the ED, and if it's triage, the patient's triage, walk right back to the hallway where the ED doctor gets up, and we evaluate the patient, decide if it's a stroke alert or not. Patients coming in by EMS, obviously we have pre-notification, stroke alert. The bottom line is both patients end up right in the hallway in the ED in front of the doctor's writing area and computer area, and we get up, we evaluate the patient. Now, once we evaluate the patient, obviously we do our focused neuro exam. Now, if you go by the American Heart Association diagram, which would be, I would love to have here for you, but the American Heart Association diagram, obviously focused exam, general assessment, you're supposed to take 10 to 25 minutes, get the patient into the CT by 25 minutes, then report at 45 minutes, and then fibrinolytics or thrombolytics at 60 minutes. Well, obviously we all know that's much too long. We certainly are trying to improve that. Get with the guidelines is moving towards changing those numbers, and what we're doing is we actually have this pit crew mentality where everybody is involved. Now that includes the secretary, that includes the charge nurse, that includes the ER techs. The ER techs are putting in the lines, they're getting the AccuChecks, they're getting all the patient ready, hopefully 2 lines if necessary, if we're given TPA and another medication for blood pressure. And then we also have, obviously, we're very lucky to have stroke ARNPs at our place, so that during the day, or at least daytime hours when they're also in the facility at the bedside. And we're also very fortunate because we have a very active strokology, neurology team that comes down. A lot of times that we're interviewing the patient and the family at the exact same time simultaneously. So that helps us. So we have all these players involved. Excuse me, we make the initial determination at a stroke scale. If it's 6 or above, not only is neurology notified, but interventional neurology is notified. We call Nils and his teams, and we get them pre-notified. Now, we also use something called the GroupMe app. I don't know if anybody's familiar with that. GroupMe app is on a cell phone. You can download it. You can use it. We use it for STEMIs. We use it for strokes. We use it for sepsis alerts. We use it even for our rapid hip alerts. And we have the identified physicians and necessary individuals, be it anesthesia, be it whatever, who needs to be notified in those cases. And these patients, these physicians and necessary professionals are activated all at the same time utilizing this GroupMe app. Now, it is somewhat of a poor man's Pulsera. It doesn't have all the bells and whistles, but it notifies everybody accordingly that needs to be notified to get them ready for potential intervention. At that point, the patient is obviously taken to the CAT scan, just like you all do. We're all interested in getting these patients there, from a quality perspective and an efficient perspective. And we placed at our hospital, we have actually something that we found to be helpful for EMS personnel that come in that aren't familiar with our facility. We have placards on the ground, and we have hearts that take them right to the cath lab for cardiac, and we have brains that take them right to the interventional neurology suite. So if the EMS is not familiar, they take them right to that area, and somebody doesn't have to go with them all the time. So that helps. Obviously, the CAT scan is done initially. And as soon as the CAT scan is done, it's plain CT, TPA is administered, obviously no contraindications, just like you all do. And we try to do that in as much of an expeditious time as possible. At that point, CTA, CTP is done if the NIH is 6 or greater. And based on that, the neurologist, the ER doc, and the interventional neurology are all involved in making the decision. Particularly, it falls to the interventional neurologist as far as whether or not that patient is going to go for an intervention or not. So this is essentially the way we work it there. We feel that we have it fairly fine-tuned. We do have some issues with certain different variables every once in a while, just like everybody does at every institution, depending on day or night. But we're still working on it, we're still tweaking it, and we're still, trying to get to the best potential we can. Now, we all have these conversion reaction patients, as Dr. Ionita mentioned in her lecture, these stroke mimics, and these conversion reaction patients, as I very like to call squirrels, that come to the hospital. These are the difficult patients. A lot of times they really can fool you, and you have to be pretty generous and pretty open and keep an open mind as far as your examinations, etc. Because a lot of times there have been a couple where I'm sure all of us have thought that these were conversion reactions and actually turned out to be true emergency strokes. So with that, the only other thing I would say is that, what all of you do, the thing that we all take for granted, and the one thing I want you to remember, and I'm sure we all forget this, is that this is not an easy job. This is hard. Everybody cannot do this. What you're doing is really phenomenal work trying to get these numbers down. I know our numbers are coming down. We're sitting right now at about door to needles of about 30, 31 minutes in 2016, and door to groins at about 82 minutes, something around there. And we're trying to improve that as well. And I'm sure everybody is, because obviously if it was your father, your mother, your grandfather, we all want to do what's going to be best for them. We all want to give them the best chance of survival and less morbidity. So with that, again, what you do does matter, and it's very important to continue what you're doing and carry on. Any questions?
I just want to make a quick comment, and that is the importance of the PIDS crew model is that in a busy ER, it's very easy for the ED physician to get sidetracked by something else, where the paramedics actually act as a pacemaker, because they're not going to go away. They're drumming their fingers, they want their stretcher back. You can't get their stretcher back until you have that patient uploaded onto the CT table. So that acts as a pacemaker, versus if they go in the room behind the curtain, like you said, automatically they're strep 5-10 minutes, I think. So I think it's a very important tool to keep everybody honest. That's why we rolled it out really to all of our facilities.